Hello, everyone. I'm Dr. Vishwarup Chatterjee. Firstly, before I start this video, I would like to thank each and every one of you who has given me, who has shown those kind of love in my previous video, and it is a lot for me, because I'm very new to this space, and I want to grow as a person. I want to grow this community, and I believe in my mission. And reading the comments in my from my previous video, I feel that I'm on the right track. And eventually, I know it's in the very early stage, and eventually, I feel that I'll reach somewhere. But without your support, I don't think I can go far. So please, support me in my mission. And if you feel that I can make a difference, I can give back something to the community, join me in my mission. I just don't want to create a channel. I want to create a platform where anyone can come and teach people. So thank you again. Well, to be honest, I'm not a conventional lecturer. I honestly do not even have any degree or teaching degree. I'm just a fellow friend and a colleague, who just wants to, raise a helping hand. And teaching is something. It's like more of like a passion. It started off from my med school, and all and it stuck to me till now. And also, I just want to make one thing very clear. That is, my videos are not exam oriented. Instead, we'll focus on building strong foundations in medicine, because I feel, what, if our basics are clear, every exam, every rotation, and every clinical decision which we are going to make as clinicians in the future will become much easier. So it's important that we have a very strong foundations of medicine. And also, since we are learning and growing together, if at any point of time you feel that I have gone off track or missed something which is very important, please comment below, because your feedback will help us to develop a better and a deeper grasp of our concepts. Something very nice happened to me earlier today. I was going through my Instagram. I came across a very inspirational video by one of my colleague, and that particular said person scored exceptionally well in the NEET PG exam. So my fellow non-Indians, NEET PG is a entrance exam to enter the residency in here in India. And mind you, it's one of the most difficult exams in the world. Not the most difficult, but one of the most difficult exams, which I feel. And what they mentioned, that said person said that they have revised the entire course. Now NEET PG is a humongous course, and that person have revised the course for more than 10 times. Can you imagine how mundane that sounds and how difficult it is to pull off something like that? But imagine the level of mastery that requires, and it's highly commendable. So my take home message is keep revising, revisit the concepts again and again, because we cannot learn medicine. It's not humanly possible to learn about this human body in one day. So that's why I will urge everyone to please keep revising the concepts again and again, so that it becomes crystal clear and stays with you for life. Again, I just want to focus on the fact that my videos are not at all exam oriented, and I do not claim that by watching my videos you will clear xyz exams. So a little bit about me. I've completed my mbbs, then I have done my masters in public health from University of Brighton and Sussex, back in UK. I was very much interested in public health at that point of time, but after completion of my degree, I came back to India, gathered some clinical experience. In the meantime, I've given exams such as your PLAB exams, your MSRA, MRCP. But to be honest, the amount of knowledge or the foundations which I have built over the years was studying from USMLE Step 1. And those whoever have given USMLE Step 1 know what I'm talking about. So it's very important that we keep this strong foundation in our mind. So how are we going to study over here? We'll follow a very system wise and a subject integrated approach. Let me break it down for you. So we'll start from, like, for example, we'll start the first video which I'm going to do today is cardiac anatomy, and then we'll move on to cardiac physiology, and eventually we're going to learn about the pathologies and the cardiac pharmacology, and so that we can build layer by layer, and at the end we can summarize everything, and it's going to stay with us. So I feel that's the best way to understand the system, because you just cannot study subject wise. It becomes very, for me personally, it becomes very messy. So I don't like that approach. I like the system wise kind of a thing. It gives me a clarity of where I'm heading, a proper orientation which I get. I would like to start off by just saying that in my first year of MBBS, one of my physiology lecturer told me that, Vishwarup, if you don't know physiology, I don't think you can build on to you can learn important topics. And it kind of stayed with me for life, and I feel that my sir was absolutely correct, because if we don't know the basics, we will not be able to build on it. So enough of the chit chat. Let me start off by cardiac anatomy. Now, anatomy as a system, it's important. It's very important. It's one of the most high yield systems which I've studied over my learning curve, and it is mm, a bit tricky, not completely straightforward. But if we start off with the anatomy, and if we have a proper orientation of how the heart works, it becomes easier. So, I would like every one of you to take a very good look at this picture. Now, this picture is something which is very important, because we are going to study about few important terminologies within this picture. So we're going to be studying about the chambers of the heart, predominantly the chambers of the heart, and we're going to have a proper orientation of the blood flow or the circulation which is taking place within the heart. Now, moving on. So this is my first slide. So the first most important thing, it's the overview of the heart. Now, what is heart? Since class 10, I've studied that heart is a muscular, it's a four-chambered organ. We all know that. It's a thick muscular four-chambered organ which is located in our chest, in our cavity, in our thoracic cavity. Now, the heart is a muscular four-chambered organ which is responsible for maintaining the blood circulation which throughout our body. Our body receives all the blood from the heart. Now, what are the chambers? There are two, predominantly there are four chambers. So, but we're going to segregate those two chambers accordingly, based on receiving chambers and the pumping chambers. The receiving chambers will be your right atrium and your left atrium, whereas the pumping chambers will be your right ventricle as well as your left ventricle. And there are two valves. So the right atrium, I'll move back to this picture. So you see those, the right atrium and the right ventricle, and the left atrium and the left ventricle. So the right atrium and the right ventricle and the left atrium and left ventricle will have the atrioventricular valves, whereas the right ventricle and the left ventricle, and in between the aorta and the pulmonary trunk, will have the semilunar valve. That is what I wanted to emphasize on. One second. Yeah. So, and also I'll be pointing out few high yield topics from here, and also we'll be doing some clinical relevance, because it's very important that whatever we learn, we relate clinically. So the high yield will be the left ventricle has the highest workload and the thickest wall. But in my mind, I'll be honest with you, whenever I think of heart, the left ventricle is the first thing which pops in my mind. So it's very important that we know that the left ventricle has the highest workload, and since it has the highest workload, it will have the thickest wall. Another high yield fact, which is very important, that the valves, both the atrioventricular and the semilunar valves, will have no blood supply, and it relies completely on passive diffusion. Okay. Now, the first chamber, very important, is your right atrium. Now, I'll just move back to the picture so you can see your right atrium over here. So why am I showing you this picture? Because I want you to have a proper orientation in your mind. So coming back, so your right atrium receives deoxygenated blood specifically from three parts, which is your superior vena cava, your inferior vena cava, and the coronary sinus, which is located within the right atrium, and it's one of the major structures present within that chamber. So superior vena cava will drain all the blood from your upper limbs. The inferior vena cava will all drain all the deoxygenated blood, of course, deoxygenated blood from the lower limbs and the coronary sinus, and then eventually into the coronary sinus, and then moves into the right atrium. So now the blood has come in the right atrium. So the blood has reached the right atrium. The blood is over here. Now it will move into the right ventricle through this tricuspid valve. Simple fact. Something which we should not, shouldn't stress on. But it has a smooth posterior wall and a rough anterior wall. Something very low yield, according to me, it's a low yield fact because it's not something which is tested frequently in exams. But the high yield fact is this SA node, the location of the SA node. Now, SA node, we know that it's the pacemaker of the heart and it's located within the right atrium. So the SA node is located in the upper posterolateral wall of the right atrium. So they can ask you within the MCQ, they can ask you the location of the SA node. The options can be in the right atrium or the upper posterior. It can be straight, like a straightforward right atrium can be one of the options. But like we have seen, the exams are not that straightforward. So they can give you the location, like the upper posterolateral wall or the lower anteromedial wall. Getting it? There can be n number of options, but the upper posterolateral wall is the actually correct answer. And what's the clinical relevance? ASD. Of course, ASD. ASD is something which will cause you a fixed splitting of S2 to your S2, which is your second heart sound. Now, second heart sound is caused because of the closure of the uh, aortic valve first and then the pulmonary valve. I'll get into those details later on when I'm going to be studying about the heart sounds and later in the future. But for right now, we need to remember that ASD can cause fixed and wide splitting of S2. So imagine you're a physician, you're working in the OPD. There is a young patient who comes to you with central cyanosis, and you listen to their heart sounds, and you notice a fixed and a wide splitting of S2. Your mind should go into ASD, which can be one of your top differentials. Moving on, your right ventricle. So we have studied about the right atrium. Now we are moving into the right ventricle. And we have already emphasized the fact that the blood flows from the right atrium to the right ventricle through the tricuspid valve. So the right ventricle receives blood through the tricuspid valve. Then the right ventricle will pump the blood into the pulmonary trunk through the pulmonary valve. Now, pulmonary valve is one of the semilunar valves. We have discussed that previously. Again, the important structures which you should know, which is present within the right ventricle, is your trabecular cardi, your papillary muscles plus your chorda tendineae, and your moderator band, which carries the right bundle branch fibers, or the bundle of his. Not exactly the bundle of his. I beg your pardon. I take back my words. You carry the right bundle branch fibers. I'll suggest you please just take a look at the. If you are a visual learner, take a look at the images which is present in Google, just search for it, and then, but it's something I have not encountered. I've given exams, and within the exams I've not come across questions which ask this kind of questions. But I did come across that the right ventricle is the most anterior chamber of the heart. So I'll give you one clinical vignette which came in my step 1 or my MRCP part 1. I'm not clearly sure about, but it was a young man who comes with a anterior stab injury, stab wound, and they have asked that which structure of the heart is most prone to this damage. I think it was in MRCP part 1, and it's your right ventricle. So that's a very important clinical fact which you should remember. And what's the clinical relevance of it? The right ventricular hypertrophy, which takes place in chronic lung disease, or your COPD, which will eventually cause cold pulmonary, and it'll cause a right heart failure. And we know the sign and symptoms of when we'll discuss about the sign and symptoms of both the right heart failure and the left heart failure later in pathology. Now coming to left atrium, I'm sorry if I'm rushing forward, but I don't think we should be spending a lot of time in it, because this is something which is very basic, and it's something which we can understand in a day or two. But keep revising again and again, especially the high yield fact and the clinical relevance. Now the left atrium. So we have come from, let me get back here. So the blood came from superior vena cava, inferior vena cava, right atrium, right ventricle, through the pulmonary artery, went back into the lung, got oxygenated within the lung, and then came back with the help of the pulmonary veins back into the left atrium. Now, veins as such, we all know that it carries deoxygenated blood. It's something which I have learned a long back. So, but the pulmonary vein is the only vein in the body which carries an oxygenated blood. Something very, I find it very interesting, and it always stuck with me since my school days. So left atrium. From the left atrium, the blood again through the mitral valve, it moves into the left ventricle. Okay. So left atrium then moves through the mitral valve, goes into the left ventricle. Okay. What's the most important factor about left atrium? Mitral stenosis, left atrial enlargement, and left atrium is the most posterior part of the heart. And left atrium, and in mitral stenosis, there is a left atrial enlargement. And since left atrium sits right in front of the esophagus, if there is an enlargement, it is going to compress the esophagus, and then that's going to cause dysphagia. Very important. I cannot emphasize the fact that how important this concept is, because there can be a clinical vignette where there is a mitral stenosis, there is a mid-diastolic murmur which is heard, and the person is facing dysphagia. So the answer is because of left atrial enlargement. Now, moving on to the left ventricle, told you before, the most important structure, the thickest of all, and pumps blood to the heart or to the body. So it will receive the oxygenated blood from the left atrium via the mitral valve. It will pump blood into the aorta via the aortic valve. An aortic valve, we have already studied that it's one of the seminal valves. And left ventricle is 3 times thicker than the right ventricle, and we know why. And again, it has dense trabecular cardiac and strong papillary muscles. But however, the high yield fact is that the left ventricle forms the apex of the heart, and the apex of the heart is present in the fifth intercostal space, midclavicular line. Moving on, left ventricle. What's the clinical relevance? Left ventricular hypertrophy is seen in systemic hypertension and aortic stenosis. And left ventricular hypertrophy, how can we see on an ECG? It's the QRS spike. If it's more than 5 large boxes on the up, that means we can indicate that the person is having left ventricular hypertrophy. And then if you check their past history, they might have a diagnosis of a systemic hypertension, or they might not be compliant with the medications. So eventually that brings us to the end of this first lecture. I do not want to stretch. It's 18 minutes and I can't believe how long it is. And these are the few references. So I've made these notes not just like on my own. I've studied Harrison first, but predominantly I've studied Davidson, Harrison here and there. I did study Harrison here and there, and while making the notes, I have used Harrison and Guyton and Hall. My favorite book, one of my best books, Guyton and Hall and Davidson. So I have the notes are basically a theme which I have taken from these 3 books. And it's very important as a medical student that at least we study Davidson. For me, the number 1 book of medicine. And there is this 1-page quick revision note. And you can always go back to my lecture and see this note. And this might help you in the before, just a quick revision. And remember the high yield facts. The high yield facts are very important. ASD, fixed splitting of S2, your right ventricular hypertrophy, your cold pulmonales, your aortic stenosis, your systemic hypertension can cause left ventricular hypertrophy. Right ventricle is the most anterior part of the heart. The left atrium is the most posterior part of the heart. Left atrial enlargement and dysphagia and mitral stenosis and the stab injury can affect the right ventricle the most. So thank you so much. I know it's a long video. I hope I can come back with another video as soon as I can. And please show me the support which you have been showing it until now. And eventually we'll build a community where every one of us can study high quality medical education. We all have the right to have a high quality medical education. And that's me signing off for now. I'll be back very soon. And if you like the video, please like, share, and subscribe. I hope I'm right. It's my first time. Thank you. Bye bye.